Hello guys, good evening and greetings. Welcome back to another YouTube session. In this particular session, we'll be discussing on the approach to diagnose and treatment of infective endocarditis, which is a very important topic as well for exams. When it comes to infectious diseases as well as when it comes to cardiology, it's a very important topic. If you guys are already there, shall I get some replies so that I'll be able to start the session, so that I can be very certain that my audio visuals are clear. My audio visuals are clear? Okay, if my audio visuals are clear, then I think we can start with the session, because basically I'm planning this to be a 1 hour session probably, so that's why we need to start it pretty early. Okay, fine. So if you can hear properly and see me, you can give a thumbs up. So I'm going to start with the session. So first of all, what do you mean by the term infective endocarditis? I'm going to show a little bit of videos as well, so please stay attended and stay tuned in this particular video. So don't jump to a conclusion that this is going to be just another infective endocarditis video. I'm going to really show some of the important pictures as well as the videos in this particular session. So if you ask about what do you mean by infective endocarditis is basically an infection of the endothelium of the heart. So I can call it as an endothelial infection. So why I'm reiterating this fact? Because many students do think that infective endocarditis is basically an infection of the valves. No, it's not. It's an endothelial infection. So in the sense, like, it could be anywhere in the endothelium of the heart. It can form an endomyocardial abscess. It can cause a valve ring dehiscence, especially in the setting of prosthetic valves. So it can cause a lot of other stuff. So that's why you need to know, first of all, that this is basically a endothelial infection rather than just a valvular infection. So that's point number one. So what are the predisposing conditions? So second thing to know is the predisposing conditions with regards to infective endocarditis. So one, you can remember in the setting of an abnormal valve, and second, in the setting of risk of bacteremia. These are two places where you are going to have a high risk of developing infective endocarditis. So first, let me talk about the places where you can have an abnormal valve, and second, where you tend to have bacteremia. So because of bacteremia, you might get a sepsis kind of a picture, and that can cause an infection of the valves or probably anywhere in the endocardium. So when you talk about an abnormal valve, and again you can split into two things. So one is going to be a high risk for developing infective endocarditis, and probably a low risk valvular lesions that can result in development of infective endocarditis. But there are quite a few important points that are important for exams. For example, if they ask you which of the valvular lesion that has the highest risk for developing infective endocarditis, you talk about a mitral regurgitation. So that is going to have the highest risk of developing infective endocarditis. If you talk about a valvular lesion that has the lowest risk of developing infective endocarditis, I think you would have studied this already. So that's going to be a mitral stenosis. So that's going to have the lowest risk of development of infective endocarditis out of all. Suppose if there is an option called MVP without MR. So this can be considered as even more low risk compared to that of mitral stenosis, because here you don't even have a regurgitation. It's just a mitral valve prolapse, and that's not even going to result in infective endocarditis by any chance. So the risk is almost zero in a patient with MVP without MR. But if you don't have an MVP without MR in the option, then the least risk of infective endocarditis in which valvular arteries, it's going to be mitral stenosis. So similarly, if they ask you about congenital heart disease that has a highest risk of developing infective endocarditis, and the most common congenital heart disease which has highest risk of developing infective endocarditis is going to be VSD, ventricular septal defect. And the congenital heart disease is which has the lowest risk of developing infective endocarditis, of course it's going to be the atrial septal defect. So what all these things really tell is the fact that whenever the gradient is high across the chambers or across the shunt, for example, in a patient who is having mitral regurgitation, the regurgitation happens during the systole. So where the ventricular systole regurgitates into the atrium during the systole. So the atrium is actually subjected to ventricular pressures, which are quite huge, and the blood that is moving into the ventricle into the atrium across the mitral valve is going to go into the atrium with such a high velocity that's going to cause severe shear stress and damage to the valve, so that there is a high risk of development of infected endocarditis. So the thing is the gradient. So that's what we need to know. So whenever the gradient between the two chambers is very high, there's probably a high risk of developing infected endocarditis. Then why not in mitral stenosis? The same thing explains you. Mitral stenosis is something that happens during diastole and not during a systole. So because of that, during the diastole, if you see the pressure differences between the atrium and the ventricles, it's actually quite low. So the pressure difference is almost zero and negligible. So there's no much pressure difference between the atrium and the ventricles during diastole. So that is the reason why MS carries a very, very low risk of development of infected endocarditis. Similarly, in VSD, if you see the pressure difference between the left ventricle and the right ventricle during systole, it's obviously very high. So that's why VSD carries a very high risk of developing infected endocarditis. Whereas if you see the pressure difference between the left atrium and the right atrium at any point, so their pressure difference is quite negligible, so that's why it has a low risk of development of infected endocarditis. So first of all, what you need to know is the abnormal valve. So that can result in the development of infected endocarditis. So what are the abnormalities in the valve that are considered to be high risk? So one is, of course, the prior infected endocarditis, because the damage that is done to the valve is done, and there will be some element of abrasions and erosions over the valve if there is a prior infected endocarditis, and that's definitely going to result in future high risk of development of infected endocarditis. And next, if you have a prosthetic valve, of course it's a foreign body, and the blood supply will not be that great, and the immunity will not be reaching to this particular area with that high penetration. So that is the reason why prosthetic valves are always at a high risk of development of infected endocarditis. And third thing, any unrepaired cyanotic congenital heart disease. So especially if they are unrepaired, they carry a very high risk, unrepaired cyanotic congenital heart disease. And number 4, if the patient is having a rheumatic heart disease, especially if they have lesions like MR and lesions like aortic regurgitation, they carry an extremely high risk of development of infected endocarditis. And any aortic valve disease. Any aortic valve disease carries a high risk. Apart from that, if the patient has any devices within the heart, you have a lot of devices. For example, device as such we divide into two. So one, we can call it as the CAEDs, classic cardiovascular implantable electronic devices. In CAED, once again you have two things. So one is going to be the permanent pacemakers, and second one is going to be the ICDs. So that is implantable cardiovascular defibrillators. Both these things will come under CAED, that is cardiovascular implantable electronic devices. And apart from that, you have mechanical support devices. These are called MSDs, or mechanical support devices. The best example for a mechanical support system is a VAD, that is ventricular assist device. So these are the devices that can result in the infection of the endocardium of the heart, which can subsequently result in infected endocarditis. But I do believe that this VAD is the one that really carries a very, very high risk of development of infected endocarditis among everything, because of, again, the sheer stress that is created on the blood because of the rotation of the motor in this particular device. At the same time, they are more internally placed and they are more interlinked with the heart compared to the other devices. That is the reason why VADs carry a reasonably high risk of development of infected endocarditis compared to the other devices. But nevertheless, you have to divide the device-related infections into two, the CAED and MSD-related infections. CAED means the permanent pacemaker or the ICD, and MSD-related infections means you're talking about a ventricular assist device in this particular perspective. And there are some conditions which carry not a very high risk, but still a low risk. Still the risk is there. So one is going to be the mitral valve disease, which I have discussed already. Generally not a very high risk compared to the aortic valve disease, but still they do carry a risk of development of infected endocarditis. For example, you have a mitral valve prolapse, especially with mitral regurgitation. I told you some time back that mitral valve prolapse without MR usually does not carry a risk of development of infected endocarditis. And apart from that, just thickening of the leaflet, which is very common in mitral valve prolapse again. Thickening of leaflet of the mitral valve, which can happen in rheumatic heart disease, or probably which can happen in any case of mitral valve prolapse, is again a risk factor of development of infected endocarditis. And here something called hypertrophic cardiomyopathy. It could be obstructive or non-obstructive. There are multiple different types of hypertrophic cardiomyopathy, but nevertheless, hypertrophic cardiomyopathy still carries a risk of development of infected endocarditis. That's why the guidelines are framed later on. When you talk about the prophylaxis of infected endocarditis, there are certain guidelines which tell you, especially the ACHA 2013 guidelines clearly tell the prophylaxis will be given usually for high risk disease only. We're not going to give prophylaxis for low risk patients, but nevertheless. So these are the high risk and low risk features with regards to the abnormal valve that is going to cause relative risk of infected endocarditis. Then coming to the bacteremia. Bacteremia means it's not directly related to the heart, but still there is a sepsis somewhere else in the body, and that is actually creating a sort of septicemia, and that bacteria that is coming as a form of septicemia is actually adhering to the valve and causing a sort of infected endocarditis. So what are the risk factors for development of bacteremia? Bacteremia, again, you can divide into primary and secondary bacteremias. When you talk about a primary bacteremia, it means there is a direct inoculation of the organism into the bloodstream. Like for example, whenever you have a peripheral IV line that gets infected, or probably a central venous catheter in an ICU patient, or probably a patient who's undergoing hemodialysis. All these are classic examples, by the way. So where you directly inoculate the organism into the bloodstream, which can result in the development of infection and sepsis and subsequently infected endocarditis. Or it could be a secondary bacteremia, which means it's quite rare. For example, you have infection elsewhere, for example, a significant pyelonephritis causing a sepsis, and that is causing infected endocarditis. So these are quite different. So anyway, so bacteremia, as I told you, is divided into primary and secondary cause of bacteremia, but there are certain people who are at extremely high risk of development of bacteremia and sepsis and thereby infected endocarditis. Who are they? The first one is going to be the IV drug uses, very common in the Western countries, but in India still it's common, but it's not coming to the surface as much because we are quite unaware of that. And whenever the patient is having an indwelling catheter, like a central venous catheter, always has a very high risk compared to that of the IV cannulas that we routinely use, the peripheral IV cannulas, but the central venous catheters generally tend to have a very high risk of development of infected endocarditis, by the way. And apart from that, it can result from poor dentition, because whenever the dental hygiene and dental caries are poor, dental hygiene is poor, so that like any dental manipulation or even without dental manipulation, sometimes spontaneously the bacteria can come into the bloodstream from the oral cavity, and they can cause infected endocarditis because of bloodstream infection. And apart from that, you can develop during hemodialysis. Hemodialysis itself is a sort of immunosuppressed state. So apart from that, the patients will be usually having multiple peripheral IV cannulas while doing a hemodialysis, or probably even a central line if they are very unfortunate and they're having AKI. And any prosthetic material in the heart, like for example, you have a pacemaker, you have an ICD, or probably a graft tissue like a Dacron graft that is used to sew up certain areas in the heart, especially in the setting of a congenital defect. So anyway, any prosthetic material in the heart is going to cause a very high risk of developing bacteremia. And apart from the diabetes mellitus itself is going to be a risk factor for this. So first of all, we need to know the predisposing conditions. As far as the predisposing conditions concerned, as we discussed, let me recap. It's either due to the abnormal valve, or even in the presence of a normal valve, you can still get infected endocarditis just because you are going to result in the development of bacteremia because of some infection and sepsis. Apart from that, we need to know the clinical features, and we need to know what are the echocardiographic findings. I'll show you in the form of video in some time. And apart from that, we need to know the treatment, at least the basic treatment, even though if there is time, we'll discuss the prophylaxis, otherwise we won't be discussing. So what are the clinical features of infected endocarditis? One second. Okay. So what are the clinical features of infected endocarditis? There are quite a few important clinical features. For example, there are features that happen due to persistent bacteremia, number one. Yeah, thank you, Samuel. Even I'm glad to see you here. Nevertheless, so persistent bacteremia. So what are the features that happen because of persistent bacteremia? So one, most important, the fever. Fever is supposed to be the most common symptom in patients with infected endocarditis. More than 90% of the patients with infected endocarditis, may it be acute or may it be subacute, tend to have a sort of fever. And apart from that, they tend to have a lot of constitutional symptoms. Like for example, they have night sweats, they have anorexia, they have fatigue, they have weight loss. These are traditionally called as constitutional symptoms, which can result due to underlying sepsis and infected endocarditis. And apart from that, many of the patients will be having associated rigors, so many of them. Especially in patients who are having acute fulminant Infectiocardis, rigors is one of the very important feature. But nevertheless, so these are the features that happen due to perstembectomy. Apart from that, there are quite a few manifestations that happen due to septic emboli. You know what are they? So because of septic emboli, you can get the petechiae. So that's a very characteristic. So petechiae in the sense you have skin petechiae elsewhere. Like for example, let me show you certain images. So here you can see these are the petechiae that happen in the conjunctiva. And these are the petechiae that happen in the palate. So these are the palatal petechiae. So these are quite common in patients with infected endocarditis. And apart from that, they can result in the development of some organ damage. For example, if it's a left-sided infected endocarditis, which means if it's affecting the mitral valve or the tricuspid valve or any area in the left side of the heart, then you are very likely going to result in stroke. You can result in development of mycotic aneurysm in the CNS, which has a very, very high risk of bleeding. So they can result in the development of subarachnoid hemorrhage as well. That is why infected endocarditis is one of the very important contraindication for thrombolysis in stroke. So you don't do thrombolysis if the patient is having stroke due to underlying infected endocarditis. So that is the take-home point. So if you correlate that, if the patient is coming with a stroke, one of the important contraindication to intervention or thrombolysis is presence of underlying acute infected endocarditis. Very, very important point. Apart from that, this is an image that shows a sort of a mycotic aneurysm happening in a patient with infected endocarditis. Apart from that, this is an image, this is actually a gross image after the death of the patient that was obtained. This is an autopsy image that clearly shows that the patient is having a brain abscess because of infected endocarditis, which means that even could be the reason for development, one of the important complications that happen in these patients. So subarachnoid hemorrhage, so I can write brain abscess, that is again due to development of septic emboli. One of the important causes of brain abscess is infected endocarditis. Even though you would have studied a few important causes of brain abscess in your ENT itself, like for example, sinus infection can result in frontal lobe brain abscess, and ENT infections, especially the ear infections. The otitis media can result in temporal lobe brain abscess, but nevertheless, in patients with infected endocarditis, the brain abscess typically happens in any area, especially in the MCA territory. So you have to be very aware of that. And apart from that, they can result in infarcts of multiple areas. So mesenteric ischemias, not only the brain, they can go for mesenteric ischemias. They can go for renal infarcts, kidney damage, renal infarcts. And they can go for splenic infarcts, so which can result in splenic drop. So whenever you have a splenic infarct, you have very close, very narrow differential diagnosis, in the sense like you don't have much underlying diseases if you have a word called splenic infarcts in your exam. Whenever you talk about splenic infarct, usually there are only two differential diagnoses. One is going to be the infected endocarditis, and second one is going to be the polycythemia vera, even though it can happen in the setting of a non-Hodgkin lymphoma, or probably even it can happen in the setting of probably a tropical splenomegaly due to malaria. So these are the situations where they told splenic infarcts can happen, but nevertheless, in real practice, it's only two. One is infected endocarditis and second is polycythemia vera, or any proliferative disorders. So apart from that, myeloproliferative disorders, apart from that, you don't have much differential diagnosis of splenic infarct. So that's a very important point as well. Apart from that, they can cause severe arthralgia. So these are the clinical features that happen due to the septic emboli. And then there are some features that happen due to the development of immune complexes in patients with infected endocarditis. Of course, whenever you develop immune complexes, it causes sort of a type 3 hypersensitivity reaction, which can result in the development of arthritis, which can result in the development of glomerulonephritis. And many patients do develop a positive rheumatoid factor. In fact, one of the important differential for having a positive rheumatoid factor in the blood is infected endocarditis. Apart from that, they can have a elevated erythrocyte sedimentation rate. And apart from that, the patients can develop valvular problems. Because the valvular problems, patients can develop a new murmur, or they can develop a worsening of the murmur, which is already there. So new murmur is the one that is seen in almost 70% of the patients, which is quite common. And the worsening of the murmur can happen in approximately 20% of the patients. And apart from that, patients can go in for, because of why these murmurs are happening, that is because the new valvular regurgitation that happens. So if the valvular regurgitation happens relatively acutely, the patients can go for heart failure and they can develop flash pulmonary edema. If it's happening more subacutely, like in virulent Streptococcus, they can develop a gradual heart failure, but especially in acute virulent infections like Staphylococcus aureus, they tend to have a acute heart failure, which is going to be even more dangerous, because anything that is acute in the heart is quite dangerous. So they can go for rapid flash pulmonary when they can die. So that's one important thing that you need to know. Apart from that, they can develop conduction abnormalities. Conduction abnormalities as well. So like prolonged PR interval, they can develop AV blocks, they can develop a lot of conduction abnormalities, because whenever there is a conduction abnormalities, it indicates a perivalvular infection. It indicates a perivalvular infection, probably forming an abscess or something like that. Remember, most of these features may or may not be present in all the patients, in the sense like, for example, an acute infected endocarditis patients due to Staphylococcus aureus will be very toxic and they'll have variety of clinical manifestations. But patients who are having subacute infected endocarditis, usually due to less virulent pathogens like viridans or probably has a group of organisms, may not be having all the features. In fact, many patients can come even without fever, like maybe a sizable number, like 5 to 8% of the patients may not even have fever. They just come with fatigue and very, very non-specific constitutional symptoms. So it needs a high degree of suspicion in those guys. But nevertheless, so these are going to be the important clinical features. But more importantly, there are some traditional features of infected endocarditis that's been shown in any clinical textbook. So one is going to be this. So this is going to be the rod spots. And once again, the most important point to know is that rod spots are not very specific for infected endocarditis, in the sense like rod spots are an immunological phenomenon that happens in patients with infected endocarditis, and it can be seen in other conditions like HIV, it can be seen in other conditions like leukemia as well. So quite often they are not very specific for infected endocarditis, but even though very commonly it is seen in the setting of infected endocarditis. If at all they ask you the pathology of how the rod spots look like, usually you have a lymphocyte that is infiltrated locally, and surrounding that you'll be having edema, and along with it you will also be having a sort of hemorrhage as well. So it's basically a kind of hemorrhagic spot. So that's a very important point, which was also tested in different exams. So it's a accumulation of lymphocytes surrounded by an edema, surrounded by admixed with an hemorrhage. It's basically a hemorrhagic spot that typically happens within the nerve fiber layer of the retina. So it's often considered to be a sort of an immunological phenomenon. And apart from the petechiae we have discussed already, this is a kind of lesion that they will be regularly asking in your exams as well. These are nothing but oscillator nodes. So oscillator nodes are basically going to happen typically in the toes and your fingers. Oscillator nodes are going to typically happen in your toes and fingers. Rather than palms and the soles. It can happen in palms and soles, but happening in the palms and soles is not that common. It's a little rare. And at the same time, oscillator nodes are quite painful, and at the same time, they are a part of immunological phenomenon, which means they are due to immune complex deposition in the local area. And then you have this characteristic Janeway lesions. So basically, Janeway lesions are painless, and they typically happen more in the setting of palms and soles than your fingers and toes. Usually they don't really involve fingers and toes, they typically involve the palms and soles. So fingers and toes are a little different from palms and soles, you know that. And of course they are painless, and they are thought to be a sort of vascular phenomenon or due to a septic emboli. So that's what they believe it to be. So these are the differences. So oscillator nodes are painful, fingers and toes than palms and soles, immunological phenomenon. Janeway lesions are painless, more in palms and soles than fingers and toes, and it's a sort of vascular phenomenon. And apart from that, this is an image that is showing, this is obviously an autopsy image that is typically showing the infected endocarditis vegetations that are adherent to this particular valve. Let us move on and discuss on how to diagnose infected endocarditis based on echocardiogram. So when you do a physical examination, you're going to see, so suppose if you're examining a patient with Infectious, what you are expected to see. Typically you are expected to do the eye and ENT examination. So why eye and ENT examination? Because you need to look for the rod spots and you need to look for the petechiae, which I've told you, especially the conjunctival and the palatal petechiae, which I've told you already. Apart from that, you need to do a thorough cardiac examination, especially auscultation, because you need to look out for the murmurs, especially the regurgitant murmurs that are quite common. Usually Infectious does not result in stenosed murmurs, whereas Infectious typically result in regurgitation of the valve because of valvular deficiency and valve leakage, and because of that you might be getting a regurgitation murmur. And you need to examine for the extremities, the hands and the legs. So why you need to examine the extremities? Because you need to look for the Oscillator Nodes and the Janeway lesions. And of course, one more important finding is going to the splinter hemorrhages that are also common in patients with Infectious. Not in all patients, especially in subacute Infectious, it can happen. Not very common, like maybe 8 to 15% is the overall incidence. And apart from that, clubbing is something you need to look for. Cyanosis is something you're going to look for. At the same time, arthritis is something you're going to look for in the extremities. Why clubbing? So clubbing is not due to Infectious. It might be due to underlying disease process. For example, like cyanotic congenital heart disease, you might have an underlying clubbing, especially if the cyanotic congenital heart disease is there for more than 6 months. There's a lot of possibility the patient is having clubbing. So cyanosis once again due to underlying problem rather than the Infectious itself. So patient might be having a cyanotic congenital heart disease. And of course, patient may have arthritis, and that will be examined in the extremity examination only. And the patient's CNS should be examined properly. Why CNS? Because the patient might be having altered mental status, the patient might be having focal weakness due to stroke, and the patients may be having a lot of other signs of raised intracranial pressure as well. So we need to know that. Apart from that, you need to examine the vertebral column also. So why? Because they might be showing some bone infarcts, especially because of the septic emboli, and you have to look for the bony tenderness. And we have seen a lot of cases where the infection from Infectious have disseminated to bones and they have caused localized osteomyelitis. And we have seen a lot of cases that has caused septic spondylitis as well, so bacterial spondylitis or pyogenic spondylitis as well, which I have seen. So it's not only the pot spine that's common in our country, it's also the septic spondylitis. That's pyogenic spondylitis also quite common. One of the important factors with regards to development of pyogenic spondylitis is the Infectious. Apart from that, hemodialysis, all these things are risk factors, but Infectious also plays a very important role in increase the risk of development of pyogenic spondylitis. So that's why this vertebral column tenderness is something that is very important to note for. Suppose if the patient is having a device, if some device is there, for example like a permanent pacemaker or a implantable cardioverter defibrillator, you need to examine for erythema in the device area or local tenderness and local erythema in the device area or any abscess formation, or that's what we call as a discharge that is coming from the incision or from the device. If it is there, then again it tells you that the patient is having a probable infection in that particular area. So these are the examination points that you need to know with regards to Infectious, which might be asked in exam. Apart from that, what are the ways to diagnose? Diagnosis generally we do through blood cultures. Blood cultures are very, very important part of diagnosis, especially we're going to discuss something called as Duke's criteria in some time. So as far as the Duke's criteria is concerned, the blood cultures play a very vital role in the diagnosis of Infectious. So blood culture wise, you can do two types of blood cultures. One, you can take two blood cultures. So one culture earlier and one culture later, which are actually spaced 24 hours apart. And if you prove both blood cultures are positive, then that becomes one of the major criteria of Duke's. Even though one culture positivity is actually enough to diagnose Infectious in appropriate clinical setting, but according to Duke's criteria, major criteria of Duke's, both cultures should be positive. Or alternatively, you can take a series blood cultures, like you can take 4, 5, 6, many number of blood cultures. The fact is the first and the last blood culture should be spaced at least by 1 hour. In between, if you want how many of blood cultures you want, you can take, doesn't matter. But the majority of the blood culture should be positive. So if you take 7, at least 4 should be positive. If you take 3, at least 2 should be positive. If you take 4, at least 3 should be positive. It's just the majority should be positive. And you can take any number of blood culture. It's just the fact that the minimum time separation between the first and the last culture should be at least 1 hour. So that is what the major criteria of Dukes is telling. Apart from that, when you come to a very practical scenario, minimum you need 2 sets of cultures. 2 sets of cultures, and you have to send for aerobic bacteria, anaerobic bacteria, as well as for fungal growths, if at all you have a high degree of suspicion. This is the usual practical stuff that we do. This is what we do in practice. At least 2 cultures, aerobic, anaerobic and fungal has to be sent, and minimum 10 ml of blood should be there. That's very, very important. Remember, the more the amount of blood you collect, the more the yield is going to be. So even this applies to any sepsis, even typhoid, like the more the amount of blood you collect, more is going to be the yield of the culture. So nothing to worry. So that's what I'm going to do here. So minimum 2 sets of cultures, practically speaking. So these are the blood culture utility, and why the blood cultures are very important. So Infectiocardis is a condition that produces something called as a persistent bacteremia. That's a very important point. So why there is a persistent bacteremia? The reason is because when you take sepsis of other areas like a urinary tract or probably a GI tract sepsis or probably sepsis somewhere else. So what does it really happen is the blood from aorta is going to split out, and only that part and the part of the blood, part of the vascular system that is actually supplying that particular area will be contaminated to the organism. When it comes back to the central circulation, it gets diluted. So that's the yield of any blood culture varies from 10 to 30% depending on multiple factors, but it does not cross usually 30-40%. So that's the maximum yield you can get with usual blood cultures. But when it comes to Infectiocardis, it's not the same. So wherever may be the blood from different parts of the body, ultimately it reaches the heart. Heart is the final destination, and heart is the starting destination. Ironically, it's the starting point as well as the final point. For when you take an artery, it's the starting point. For the veins, it's going to be the final point. So which means every single ml or ounce or kilogram of blood, whatever you tell, every drop of blood will be drenched with the infectious organism. So that is the reason why this is actually the most important thing. So that's persistent bacteremia. That's going to be the most important thing, which makes you the diagnosis of Infectiocardis rather than anything else. So that's why it's very important, persistent bacteremia. So any number of blood cultures, if you take, it should be ideally, theoretically positive, because all the blood is actually coming to the heart and leaving from the heart. So theoretically speaking, every single ml of blood and every single drop of blood should have the infected organism if the heart is getting infected. So that's the basic idea of the persistent bacteremia, and that's why the Duke criteria is one of the major criteria with regards to the blood cultures. And what are the conditions where you can have culture negative Infectiocardis? Culture negative Infectiocardis. So as for the culture negative Infectiocardis, the most usual reason is the fact that the patient would have received prior antibiotics, because patient would have seen some local practitioner for fever, and they would have started some antibiotics which have reduced the bacterial load in the blood. So because of that, they might have a culture negative Infectiocardis. Or probably the patient will be having non-infective endocarditis. So in the sense, like, they are not infectious at all. For example, there are many other situations where you can see vegetations, like a merantic endocarditis we call. So Liebman-Sachs endocarditis we call. These are sterile vegetations, and they don't really happen out of infection. So a non-infected endocarditis may also have a culture negativity. And apart from that, you might be having some fastidious organisms, in the sense like they need some specialized medium for growth. For example, like Hassack bacteria. So if you don't give this that specialized medium for growth, they might not grow properly in the culture. So it could be because of some fastidious organism. Like for example, even a fungus is a fastidious organism, because you might be doing something else, a bacterial culture, but what the organism that is actually circulating in the blood is a fungus, and you'll not be able to pick up that unless and until you do appropriate cultures for fungus. So that also comes under fastidious organisms. Or it could be organisms that are intracellular and cannot be cultured. For example, a Coxella burnetii, that's the best example we can give, which is intracellular in nature, and generally that cannot be cultured that easily. So these are the usual reasons why you might end up with a culture negative Infectiocardis. The incidence of culture negative endocarditis overall is approximately like 15 to 25% depending on the amount of antibiotic abuse in your local area. So then we need to know about the organisms, the microbiology, So organisms wise, if at all anyone asks you the most common organism as a whole that happens in patients with Infectious, that is Staphylococcus aureus. That's the most common organism. And again, this is biased depending on the Western data, because in Western countries there are a lot of data coming from IV drug users, but in Indians we don't take that much data on IV drug users, and we don't see that much patients very commonly in our practice as well. That is the reason why situation in India might be a little different. Unfortunately, we don't have any exact head-on-hand data to compare the Western and the Indian patients. But nevertheless, whatever data I'm telling is based on the Western details. And according to the Western data, the most common organism as for 2019 Infectious Society guidelines is Staphylococcus aureus. More than 50% of the patients IE will be having Staphylococcus aureus in the blood. Typically, Staphylococcus aureus is the one that causes very fulminant kind of Infectious, and it will be causing very acute and rapidly progressing Infectious, and there is a very, very high risk of developing complications, especially if it's a left-sided Infectious. But if it's going to be a right-sided Infectious, generally the same Staphylococcus aureus tends to be a little benign. I'm not telling it's very benign, but little less severe compared to the left-sided Endocarditis. But if it's going to be left-sided and Staph aureus, you pray God. So it's going to be really, really severe, and they're going to end up with so many complications. Right-sided Staph aureus, maybe tricuspid valve involvement. Maybe they might have less severe manifestation, because the right-sided Infectious are generally amenable to antibiotics compared to the left-sided Infectious. That is the general rule. So let us see into two. Let us divide into two. So what do you get in native valve endocarditis, and what do you get in prosthetic valve endocarditis? So these are two situations where you're going to end up with. So as far as the native valve endocarditis is concerned, once again the most common organism is going to be Staph aureus. There is no doubt about that. Suppose if at all they give you a very acute and a fulminant Infectious, very rapid presentation, so then again we think about a Staph aureus in this particular perspective. Suppose if the examiner gives you a more subacute presentation, not a very rapid presentation, and a little bit of less severe manifestations, patient is coming with some classic skin findings, but the patient is not having severe heart failure and severe valvular regurgitation. It's more subtle. So in this condition, you think about a viridans. Viridans is not that virulent, to be honest. Virulence is a kind of organism that tend to have a low virulence, so that is why it doesn't produce that severe clinical features. When you talk about a prosthetic valve endocarditis, as far as the prosthetic valve endocarditis is concerned, the timing of development of infectious endocarditis is the most important thing. So whether you develop within 2 months or whether you develop after 12 months, so that's what's going to be more important. If you develop a prosthetic valve endocarditis in the first 2 months, very often it will be due to cons. It's actually a skin commensal. It coagulates negative Staphylococcus. There are two species out there. One is Staphylococcus epidermidis, and second one we have Staphylococcus. There's something called Lugdunensis. So spelling is Lugdunensas, Lugdunensis. So everyone knows epidermidis, and second species is Lugdunensis. Both will come under coagulase negative Staphylococcus. It's actually a kind of a nosocomial infection, and this is the one that usually affects the individuals within 2 months after a prosthetic valve implantation. And if you get after 12 months, it's usually similar to that of what you get in native valve endocarditis, which means again it boils down to Staph aureus again. So that's going to be the most common. After 12 months, similar to what you get in native valve endocarditis, within 2 months, it's usually going to be coagulase negative Staphylococcus. So what happens in the 2 to 12 months mark? We don't know. It could be anything. 2 to 12 months, we have no idea. It could be anything. Like it could be Staph aureus, or it could be viridans, or it could be cons. We absolutely have no idea. So it's sometimes it can be even polymicrobial also. But nevertheless, these are the microbiology points that you need to know. And once again, if they ask you ventricular assist device related infection, the most common organism to affect the VAD devices, once again, are Staph aureus. Very important point. And the second most common, if they ask you, answer is going to be Pseudomonas. VAD, rather than writing Staph aureus, simply we can write Staphylococcus, because it includes Staph aureus as well as coagulase negative Staphylococcus. Second most common organism is going to be Pseudomonas. So these are the two infections that are quite common in patients who are having ventricular assist devices. Alright. So now let us see about other organisms. First of all, Staph aureus wise, you need to know what is the most important thing is whether it's a MSSA or MRSA. That's what you need to know. This is the most important point to know as far as Staph aureus is concerned. Depending on that only, you are going to give the treatment, which we'll be discussing subsequently. Viridans wise, usually it produces, as I told you, very subacute infectious because of low virulence. Usually it is an organism that is present in the oropharyngeal flora. So it's one of the components of the oropharyngeal flora. And if you want to describe this, it's going to be alpha hemolytic. You would have studied in microbiology alpha, beta, gamma hemolytic. So it's an alpha hemolytic Streptococcus. And it's a component of the oropharyngeal flora as well. And it typically produces subacute endocarditis due to very low virulence. And very commonly after dental infection, you can actually expect this kind of viridans group. So if you talk about viridans group, it itself has many subspecies like your microbiology textbooks will give, that's called a sanguis, S-A-N-G-U-I-U-S. Then you have mutans, and then you have salivarius. So these are the subgroups that happen within the viridans group. But nevertheless, viridans is a oral commensal. After dental infection, if the patient gets a subacute infectiocardis, you can always think about a viridans causing infected endocarditis. Usually it's very, very sensitive to penicillin. So you need not worry much about that. Any kind of penicillin drug will be effective. Even a simple penicillin will be highly effective. When you talk about a coagulase negative Staphylococcus aureus, usually in exam, when you diagnose a coagulase negative Staphylococcus, typically in a prosthetic valve endocarditis setting, because it's a nosocomial organism. So PV less than 2 months in exam, always go for cons, as simple as that. Then apart from that, you have many other organisms which can result in development of infected endocarditis. Like for example, you have Enterococcus. As the name suggests, Enterococcus. So it's actually an organism that is coming from the GI tract. So which means it's a GI flora organism. So usually any infected endocarditis that is associated with a urinary tract infection or probably after an abdominal surgery, because Enterococcus is a very, Enterococcus very commonly contaminates the abdominal surgeries. So any intra-abdominal complicated infections and the patient develops infected endocarditis, you can think about Enterococcus in exam. Once again, it could be a nosocomial pathogen as well, rarely, but usually. So what is the usual suspicion when it comes to clinical setting as well as the exam? When a patient is having a UTI and developing a infected endocarditis, or after abdominal surgery when you have a local abdominal sepsis, and then along with that if you develop an infected endocarditis, you can think about Enterococcus as a possible organism. Remember, most importantly, treatment is difficult because it's likely to be nosocomial, difficult, and many times it could be even a vancomycin resistant species. We have a species called vancomycin resistant Enterococcus, and you have, subspecies wise you have two. One is called faecium and another one is called fecalis. There are two things are there along with Enterococcus. So it could be a vancomycin resistant species, so treatment is quite difficult. It's not that easy to treat. Apart from that, you always need synergism with aminoglycosides, which means you need to add aminoglycosides for synergism. So it's not just you need to add the sensitive drug, always try to add a gentamicin or probably even amikacin for a added synergism. And next you have HACCP group of organism. So you know what are the acronym for HACCP? HACCP stands for Haemophilus, Actinobacillus, Cardiobacterium, Eikenella and Kingella. So remember that, the species Actinobacter, the name is actually changed to Agritobacter. So Aggregatobacter. So that is the name that is changed. So previously it was Actinobacter, now it is Aggregatibacter. So that is the name that is given right now. So the new name. So in exam, if they give Aggregatibacter, don't get confused. It's just the Actinobacter of the HACCP group that they're talking about. So as I told you, it's a very fastidious organism, which means it needs special growth requirements. So it will not grow under ordinary culture media. So it needs high degree of suspicion. And it's a gram-negative bacillus. All these are gram-negative bacillus. Usually, it happens when the patient is having a URA. After a URA, if the patient develops infected endocarditis, you can think about that. But because it's a component of oropharyngeal flora, so that is the reason. Usually, it takes a longer incubation period for growth. Longer incubation period for growth in blood culture typically takes more than or equal to 5 days for growth in the blood cultures, which means if an organism is going to take a very long time to grow in the blood culture, there are two things you can think about. So one, it's virulence. So if the organism grows within 24 hours in the blood culture, that disease is going to be very severe because the organism is supposed to be very virulent. If it takes more than 5 days to grow, so usually the infection will be less severe and the virulency also will be less. So how fast the organism grows in the culture also gives you a clue in real time. But this generally tends to produce a very large vegetation. So because again they produce subarachnoid Infectious and happens over a very long period of time. So that's why they tend to give rise to very, very large vegetations most of the time. So again, they are fastidious. They are oropharyngeal flora. So after URI, if you get Infectious, you can think about this. And it usually it takes long incubation period for growth in the blood cultures. It takes at least 5 days to grow, even longer, like 10-15 days sometimes. So you have to be a little patient if you think about as a group. Very commonly, they are quite sensitive to your common drugs like ceftriaxone. So usually ceftriaxone is the gold standard drug for treating as a group of organisms. Apart from that, there are certain organisms which are difficult to grow. One is Coxiella burnetii, that is Q fever we are talking about. Usually we do by serological titers. So if it's more than 1:800, then it is considered to be significant. Otherwise, it's not. But a single titer is enough. We'll talk about that when we talk about the Duke's criterion sometime. Then we have Bartonella species. Typically results in culture negative infected endocarditis because it's like an intracellular organism. It also results in development of something called cat scratch disease. So you can think about that in the setting. So then fungal infected endocarditis. Usually risk factors for developing fungal endocarditis are serious immunosuppression. Serious immunosuppression in the sense like patient might be having a HIV or with a very low CD4 count, or probably patient is at the central line in the ICU, or patient is having a chemotherapy, or patient is a cancer patient. So in this particular setting, or patient after transplant, post-transplant scenario, you can think about having a fungal infected endocarditis. Apart from that, there are some other organisms which cannot be grown. For example, Brucella, intracellular organism again, and you have Trophirma whippleyi. If you take one of the important extra-intestinal manifestations of Whipple's disease, it is endocarditis. Even though the most common extra-intestinal manifestation of Whipple's disease is arthralgia, heart involvement can happen in quite a few number of cases, like especially the endocarditis is quite common. So Trophirma whippleyi, that is Whipple's disease, can result in the development of infected endocarditis. Apart from that, you can develop with mycoplasma, very rare, and you can develop with Legionella. All these are intracellular organisms, so very, very difficult to grow. So these are the usual reasons why you might develop a culture negative infected endocarditis. These are the usual reasons why you might result in the development of culture negative infected endocarditis. So with the help of like blood cultures, even I told you about what are the reasons for culture negativity, how you really take the blood cultures, and what is the microbiology that you need to talk about. So because if you know what's going to happen, what's the organism you are suspecting, based on that only you can give a empirical antibiotic. That's why. Apart from that, there's one organism we missed, that is Streptococcus bovis. Previously it's called as bovis, currently it's called as Galolyticus. So you can think about this Streptococcus bovis as a probable cause of infected endocarditis in GI pathologies. So whenever a gastrointestinal pathology, like for example an IBD or a colonic polyp or a colon cancer, so if you get an infected endocarditis due to an underlying severe GI manifestation, so usually in exam you can think about a Streptococcus bovis as a probable pathogen. So it's a very important point again. So we talked about the entire microbiology, isn't it? So now let us see the other investigations that can be useful for the diagnosis of infected endocarditis. Next one is the EKG. As well as, ECG is something that has to be done routinely, and any patient with infected endocarditis, you have to monitor daily, monitor almost daily. You have to do a ECG. The reason is because patients may go for a conduction block in between, which is actually indicative of a perivalvular extension and actually penetrating the myocardium and causing damage to these conduction fibers. So you need to monitor the ECG daily. So to look for any conduction blocks, especially the prolongation of the PR interval, or probably an AV block might happen. So ECG is a very important investigation, especially for monitoring. You need to do it at regular intervals. And apart from that, you can do an echocardiogram, which is quite important. As far as the echocardiogram is concerned, you're actually going to look for the mobile mass. So let us see what, I'll show you the videos in some time, but the Transforastic Echo is the one that is usually performed as a part of screening first. Then invariably most of the patients will be going for transesophageal echo. But still the first type of echo that we perform is going to be the transthoracic echo. That's actually a kind of a screening. So why then we proceed with transesophageal echo is the fact the sensitivity of transthoracic echo is actually quite less. It's only 70% for native valve endocarditis, and even lesser, only 50% for prosthetic valve endocarditis. To assess the prosthetic valves, your transesophageal echo is going to be the most important. So that's the take-home point. So if you take the sensitivity of the transesophageal echo, it's almost 96% for native valve endocarditis and 92% almost for prosthetic valve endocarditis, which means it's very clear for the assessment of prosthetic valves there is a substantial difference. For that matters, any infected endocarditis patient, they have to be followed up with the transthoracic echo. That's very, very important. Suppose this transesophageal echo is positive, whether you'll do a transthoracic echo is positive, whether you'll do a transesophageal echo or not, again, yes, you need to proceed ahead with the transesophageal echo. The reason is because you need to look for complications like abscess, fistula formation, which is best seen in transesophageal echo only. So that is why even if the transthoracic echo is positive, you need to go for transesophageal echo. Suppose the transthoracic echo is negative, whether you'll go for transesophageal echo, yes, the patient is having a high suspicion of infected endocarditis, especially a prosthetic valve endocarditis, definitely should be followed up with transesophageal echo. Even if the transesophageal echo is negative for some vegetation, still you proceed ahead with transesophageal echo because prosthetic valves are best seen in transesophageal echo only. Or alternatively, the transesophageal echo is inconclusive. In the sense like whether it's there or it's not there, you are not able to clearly find out in transthoracic echo, then still you need to go for transesophageal echo, which means transthoracic echo only acts as a bedside diagnosis or probably a screening tool. So definitely that will be followed up with transesophageal echo in majority of the cases. So TT is considered to be the gold standard imaging technique currently as far as infected endocarditis is concerned. Remember, still TE misses around 4 to 8% of the patients, depending on whether it's a native valve or prosthetic valve endocarditis. But nevertheless, as far as the imaging gold standard is concerned, transesophageal echo is the imaging gold standard, which I've told you multiple times. So what are things you're going to look for? The most important thing I'm going to look for is the vegetation on the valves. So what is the vegetation basically? Vegetation is nothing but sort of an oscillating mass, which I'll show you, which will be freely mobile on either side. So when the valve moves that side or valve moves this side, on both the sides the vegetation will be freely mobile. And what are the site of looking for vegetation in the valves? Typically in the low pressure zones. For example, you will see in the atrial aspect if your mitral or tricuspid valves are affected, or in the ventricular aspect if your aortic or pulmonary valves are affected, which means whichever side that is having relatively low pressure, that is the side where you typically see the vegetation, classically. Clear? Or you can see on the intracardiac material. Intracardiac material in the sense you can see on the leads. Intracardiac material in the sense like, for example, in pacemaker leads. You can see in the pacemaker leads. Fine. But remember, this point is very important. So you can see in the atrial aspect, if it's a mitral tricuspid valve vegetation, typically in the ventricular aspect, if it's a aortic or pulmonary valve endocarditis. But remember, typically seen in the low pressure zones, not in the high pressure zones. So atrial side is the low pressure compared to ventricular pressure, if it's a mitral or tricuspid valve, and aortic or pulmonary side, because aortic and pulmonary pressures are low compared to the ventricular pressures, if you take overall. So that's the reason why, ventricular aspect is having low pressures compared to the aortic and pulmonary side when it comes to the aortic and pulmonary valve vegetation. So that's why it's typically seen on the low pressure sides. The sides which have the lower pressures comparatively, that is the side where you typically see the vegetations. So, and it's a kind of an oscillating mass. Let me show you the video. So first of all, you see this one. You can see, this is a mitral valve vegetation. You can see a kind of an oscillating mass here. So, which moves here and there. So you can see a sort of an oscillating mass here that moves up and down. You can see this. So this is the oscillating mass I'm trying to show up. So that typically moves towards the ventricular side as well as the atrial side, but very commonly you will see on the atrial side very clearly because this is the mitral valve endocarditis. The view that we are seeing here is the plaques view, you know that. Parasternal long axis view. So where this is the left ventricular outflow tract, this is the left ventricle itself, and this is the left atrium, and this is the mitral valve. So the blood movement will be like this, and it's going out like this. So this is the view. I'm just describing the view over here. And in this particular example, you are seeing a mitral valve vegetation. So, and if you want to know which valve, it is the anterior mitral leaflet here, and this is the posterior mitral leaflet. You are typically seeing a vegetation on the anterior mitral leaflet that you are trying to see here. And the next one is the aortic valve endocarditis. Remember, aortic and pulmonary valves, very commonly vegetations will be on the ventricular side, and the thing will be freely mobile. So you can see that as well. So again, this is a plaques view which you are looking at, and this is the right ventricle, this is the interventricular septum, this is the left atrium, this is the left ventricle, and this is the aorta, and this is the aortic valve, and this is the mitral valve. And in this particular example, you can see the aortic vegetation. To be honest, you can see the aortic vegetation over here. So there is something, sort of an oscillating mass that is moving here and there, back and forth. So this is a typical vegetation that you see in the setting of Infectious. And remember, there are multiple differential diagnoses for seeing a vegetation. In the sense, like if you see an oscillating mass, it doesn't mean it's always an infected endocarditis. It could be a non-bacterial thrombotic endocarditis, or it could be just a valve thickening that happens in MBP, mitral valve prolapse, or it could be an old treated vegetation. It's non-infectious, just the vegetation is there, but it's not having an infectious organism. So it could be old vegetation which is currently non-infectious, or it could be due to some ruptured chordae, because the chordae is ruptured, which means every time the ventricle contracts, it throws up when the chordae is ruptured across the aortic valve. So that can be seen as vegetation in the echocardiogram, or a calcified area in the valve may also be seen as a vegetation. So that is the reason why when you see a vegetation or a vegetation-like structure, it doesn't mean that 100% it's a infected endocarditis. So you need to always look at the criteria. So that's why we have the Duke's criteria. You need to have a combination of major and minor features to tell that the patient is probably having a infected endocarditis. And at the same time, you're not only going to, whenever you do echocardiogram, the reason for doing an echocardiogram is not just to see the vegetations, it's also to look for the complications. Especially, very commonly, you're going to have valvular regurgitation, which is quite common. And next is you're going to look for abscess or fistula formation, and especially in the setting of prosthetic valves, we are going to look for dehiscence. So what do you mean by dehiscence? The annular ring that is sutured on the sides of the prosthesis into the myocardium or endocardium is actually tearing away, and there will be a free movement of the prosthesis in and out of the chamber. So that's like a process is completely coming out. So it's a complete tearing of the prosthesis from the sutures that are made during the surgery. So that's what we call as prosthetic valve dehiscence, and that's what we're going to look for. These are things that are to be looked for in the echocardiogram as far as infected endocarditis is concerned. And this is about an approach and clinical view of infected endocarditis. That is why I'm not discussing more on the treatment, because we are only doing a clinical approach. And finally, let's come to the Duke's criteria. So now if you understand the Duke's criteria, it will be much easier. So we're talking about a modified Duke's criteria for that matters. So it's modified along that. So what are the things that come under the Duke's criteria? So they gave the major criteria and they gave the minor criteria. So what are the major criteria? First of all, the blood culture that are typical, which I've told you. Already I've told you what are the typical positive blood cultures. Either you should have 2 blood cultures taken 24 apart and both should be positive, or you can take any number of n number of blood cultures, but only thing is the difference between the first and last blood culture should be at least 1 hour apart, and in that majority if it's positive it's enough. So usually in the very fast environment where we live in, we go for the second option because it's fast. You can take any number of blood cultures in the 1 hour time. So that is the reason. So any blood culture that is typically satisfying the rule which I have told already, that will come under the major criteria. And second, if you have a Coxiella burnetii serology, which is causing Q fever, Coxiella burnetii serology, especially if it is more than 1:800, this is something again I have discussed already. Coxiella burnetii serology, if it's more than 1:800, just a single titer is enough. You don't need a combination. Even a single titer forms the major criteria in appropriate clinical settings. And apart from that, you should have some evidence of endocardial involvement. Evidence of endocardial involvement, especially in the echocardiogram. So what are things you can look for? So typically, as I told you, I'm going to look for a vegetation, or I'm going to look for an intracardiac abscess, or I'm going to look for a prosthetic valve dehiscence, or I can look for a new or a worsening valvular regurgitation. So even though the vegetation is not seen sometimes, you can look at this worsening regurgitation without a cause. So that also will come under evidence of endocardial involvement. So these are the three major criteria that is given in the modified Lewis criteria. When it comes to the minor criteria, first one is the fever, especially the persistent fever, which is a very common thing. Second is the patient who is having predisposing condition. As I told you, the predisposing condition can be a valve abnormality, or it could be a condition that predisposes to development of bacteremia, like hemodialysis, poor dentition, intravenous drug uses, prosthetic material in the heart. So all this stuff. Number 3, immunological phenomenon. We have discussed already what are the immunological phenomenon. So you have the Oscillator Nodes, you have the rod spots, you have the glomerulonephritis, and you have a positive rheumatoid factor. All these 4 are immunological phenomenon. And then you have the vascular phenomenon. We again discussed what are the vascular phenomenon. It is all about the embolus. Like for example, it could be a myocardic aneurysm or a stroke or an intracranial hemorrhage, or a Janus lesion is also a vascular phenomenon, or a pulmonary embolus, especially if it's a right side infectiocardis, it goes to the pulmonary circulation. So these are the vascular phenomenon. And fifth one, last but not least, is positive blood cultures. You have the positive blood cultures, but not satisfying the major criteria. Not typical, not satisfying the major criteria. So what do you mean by it's not satisfying the major criteria? Which means I told you, you have to take 2 blood cultures 24 hours apart, and both should be positive. What if it's only one positive? That's also a positive blood culture only. But just because the second culture is not positive, that cannot be taken lightly. So that will come under the minor criteria. Suppose if you are taking 5 blood cultures in a span of 1 hour, and only 2 are positive, which means according to major criteria, the majority should be positive. So if you take 5, at least 3 should be positive. If only 2 are positive, which means only minority is positive, and that's not satisfying the major criteria, and that will become a minor criteria. So which means when the blood culture is positive, but it's not satisfying the major criteria, that will come under the minor criteria. According to the modified Lewis criteria, when you diagnose Infectiocardis, you can definitively say it's Infectiocardis when you have a 2 major criteria plus at least 2 major criteria, or probably 1 major criteria and 3 minor criteria, or probably all the 5 minor criteria. So with this you can say that the Infectiocardis is definite, in the sense like even if you don't have any echo evidence, you had a positive blood culture with typical vascular immunological phenomenon, a predisposing condition and a fever, you can make a diagnosis of Infectiocardis. Even without any echo evidence, you can make a diagnosis of Infectiocardis. Remember, the idea why we are telling this criteria to be a definite criteria is because none of the investigations are definite. For example, just because you have a positive blood culture, you cannot say it's Infectiocardis. Just because you have an endocardial involvement, it could be in vegetation or it could not be vegetation. As I told you, there are multiple differential diagnoses for vegetation itself. So you cannot really tell it that it's definitely Infectiocardis. So that's why whenever you seek for a clinical diagnosis, you think about a combination of features. So see the patient. So what the patient is having, whether the patient is having a particular clinical feature, and that is correlating with your diagnosis, and the investigations are supporting your clinical findings and your suspicion. So that's how you take the case forward whenever you are working in a tertiary care center. Or you can tell a probable Infectiocardis when you have a 1 major and a 1 minor criteria, or alternatively a 3 minor criteria. So this is the criteria to tell it's a probable infective endocarditis for that matters. So this is the clinical approach to Infectiocardis. Because the topic I have kept is on the clinical approach, I have just discussed on the clinical approach. I am not going to really discuss on the treatment part, and there are a lot of other approaches as well for Infectiocardis, how to treat each and every organism, how to treat a device infection, how to treat a ventricular assist device infection. So all these things are there, but nevertheless I am stopping this particular session with this. And with this, thank you very much for your patient listening. We'll see you in the next YouTube session soon, and it's a pleasure meeting you all. Thank you.